Hello everyone, today we'll discuss about an elbow shot case. Starting with the brief history, our patient is a 40-year-old male with deformity of the left elbow for last 30 years, tingling and numbness in the ulnar side of the left hand for last 5 years, weakness in left hand for last 5 years. On further interrogation, there is history of fracture around the elbow which was managed by a quack in his village, and following which he noticed a deformity in the left elbow. The deformity continued to increase for about 5 years and now static for last 25 years. Now on to the examination. On looking from the front, bilateral shoulders at equal level with arm by the side of the patient, bilateral elbow in full extension and forearm in supination, bilateral wrist in extension with digits on the affected side in flexion and extension on the normal side. There appears to be a cubitus valgus deformity on the left side. Muscle bulk of arm and forearm is comparable. However, there is wasting of muscles of hypothenar eminence on the left side. There is no obvious swelling, scar or sinus around the elbow joint. On looking from the side, the elbow is in full extension and there is no evidence of any swelling, scar or sinus around the elbow joint. On looking from the back, there is increased prominence of the medial epicondyle. Also, there appears to be wasting of interossei muscles of the left hand. Feel for the local temperature using the back of the hand and compare it from the other side. On superficial palpation, look for any superficial tenderness or any abnormal myositis mass and compare it with the unaffected side. No abnormality was found in this case. On bony palpation, palpation of lateral supracondylar ridge was found to be thickened as compared to the other side. There was abnormality in continuation of lateral supracondylar ridge. Normally, palpation of lateral supracondylar ridge will lead to lateral epicondyle. Here, there was a discontinuity between them, and a step was palpable between the ridge and the lateral epicondyle. On palpating the lateral condyle, the surface of the lateral condyle was found to be irregular as compared with the normal side. Also, there was subtle abnormal mobility which was appreciable in both the planes. The medial supracondylar ridge and the medial epicondyle were bilaterally comparable. On assessment of 3-point bony relationship, the triangle was found to be distorted when compared with the normal side. Flexion extension measured with the help of a goniometer, it ranged from 0 to 140 degrees of flexion. The arc was pingless throughout and not associated with any crepitus or spasm. Supination pronation, it ranged from 80 degrees supination to 65 degrees of pronation. The movements were bilaterally comparable and not associated with any pain, crepitus or spasm. Arm length was found to be equal in both the sides. Forearm length was again found to be equal in both the sides. Muscle bulk of arm and forearm on both the sides were equal. Measure the carrying angle. To measure the carrying angle, we need to draw an arm axis and a forearm axis. For arm axis, the proximal point is the center of line joining the anterior axillary fold and the deltoid insertion. The distal point is the center of line joining the medial epicondyle and the lateral epicondyle. For forearm axis, the proximal point is the center of line joining the lateral and the medial epicondyle. The distal point is the center of line joining the radial and the ulnar styloid. Measure the carrying angle at the intersection of these two lines with the help of a goniometer. The carrying angle on the affected side was 25 degrees, whereas on the normal side it was 10 degrees. Now on to the assessment of 3-point bony relationship. After comparison with the normal side, the base and the lateral limb of the triangle was found to be increased by 1 cm on the affected side. Features suggestive of ulnar neuropathy were present in this case, such as wasting of hypothenar eminence, wasting of web spaces, remarkably in the first web space, clawing of little and the ring finger. Sensory loss of 50% was present in the autonomous zone of ulnar nerve. After comparison with the normal side, there was weakness in flexion of the IP joint of little and the ring finger. Froment's sign was positive, suggested by the flexion of IP joint of the thumb. IGAWA test was positive due to inability of middle finger to abduct. Carr test was positive, suggesting weakness of the palmar interossei. Bouvier's test was positive, suggesting a simple claw hand. For testing the flexor carpi ulnaris, patient is asked to palmar flex the wrist and do ulnar deviation against resistance. The power was comparable in both the sides. On palpation, ulnar nerve was not thickened and there was no subluxation of ulnar nerve on flexion. So on the basis of history and physical examination, our diagnosis is a case of left-sided non-union lateral condyle humerus with cubitus valgus deformity for a duration of 30 years with tardial ulnar palsy for a duration of 5 years in 40-year-old male with right hand dominant. Here is an EP and lateral radiograph of a skeletally mature patient showing the elbow joint, distal humerus and the proximal forearm. The elbow looks to be in valgus malalignment. Moving from periphery to center, there is no abnormal soft tissue shadow. The lateral supracondylar ridge is thickened. Fracture is seen in the region of lateral condyle with margins of the fracture being smooth. Fractures seem to involve the lateral half of trochlea as well as the olecranon fossa. The anatomy of lateral condyle looks distorted. The radiodensity of the lateral condyle is comparable with the surrounding bone, thus confirming our diagnosis of non-union lateral condyle humerus with cubitus valgus deformity, probably a type 2 Mills fracture.